I'm really excited about the RETNET trial. It's the first ever multi-center global randomized controlled trial of standard of care embolotherapy. We've been doing embolization since the 1970s in France and the US, and then chembolization in the 80s, and in the 20th century we added drug-eluting beads and Y90, and there's never been a prospective randomized controlled trial of standard of care therapies, even though these treatments are in all the guidelines. So compared to the radiation oncologists and medical oncologists, our level of evidence is not very strong, and now we're going to have really good evidence. I've just presented at CIRSE 19 our first safety report. This is a randomized trial comparing bland embolization to conventional chembolization with Lipiodol and drug-eluting beads using doxorubicin. And one of the concerns going into this trial is there have been some retrospective series of drug-eluting beads in neuroendocrine tumors suggesting an elevated rate of hepatobiliary toxicity. And so people were concerned about whether this was, a true phenomenon. And of course, just like you can't say something is good without a randomized trial, you can't say something is bad without a randomized trial. So in the design of the trial, we set a very generous 20% major complication rate as the stopping rule for the study. And then the adverse events were reviewed by 3 independent interventional oncologists who had nothing to do with the study and were blinded to the treatment arms. And they looked at the serious adverse events in each of the arms. So in the bland arm and the conventional chembolization arm, there were 1 or 2 serious adverse events, of which half were not related to the study procedure itself. Whereas the drug-eluting bead arm, 4 out of 10 patients had major serious adverse events, 2 of which required the patient to go off study, 2 of which put the patients in the intensive care unit, and 2 of which were permanent hepatobiliary injuries that did not resolve. So based on this very high rate of serious adverse events, the DSMB closed that arm. And I would point out that this is actually the second prospective trial. There was a single-arm phase 2 study of drug-eluting embolics in neuroendocrine tumor done at Johns Hopkins several years ago, and it closed after 13 patients because 7 of them had major hepatobiliary complications. So now we have 2 prospective trials showing that this particular platform of doxorubicin loaded on an embolic is too toxic to be used in neuroendocrine tumors. They're still very prevalent both in the US and in Europe. As of the last practice survey, which was several years ago, about 25% of patients with neuroendocrine tumors were being treated with drug-eluting embolics in the United States. I think that the promise of the drug-eluting embolic platform is to give us new drugs for new tumors, but for delivering doxorubicin, I think it's really not effective. There have been 2 randomized trials showing that it's no better than bland embolization in HCC, and now we have 2 prospective trials showing that they're excessively toxic in neuroendocrine tumors. So I think the particular combination of doxorubicin and drug-eluting beads really does not have a role in daily practice for HCC or neuroendocrine tumors. But it could be used for delivering things like idarubicin, more potent drugs, or irinotecan for colon cancer, things we've never been able to do before with conventional chembolization. So I think it's a platform that should be explored, but I think we should abandon DEB-DOX. It's very interesting. And when I originally designed the trial back in 10 years ago, I wanted to have a Y90 arm. In fact, the impetus for the trial came from Nordion back when they were still Nordion. And then when they were acquired, that they disappeared. And neither BTG nor CTACE actually wanted to support this trial, which is the only reason why there's no Y90 arm. It turns out that's providential, because really the whole question of Y90 neuroendocrine tumors is its own ball of wax. There's a couple major concerns that have come up. There are now 3 single institution retrospective studies that have shown late liver failure in patients who are long-term survivors of Y90 therapy, and that particularly applies to the neuroendocrine tumor population because they're very long-lived. So the series from Oregon, from Northwestern, and from my own university showed that between 10 and 20% of patients who live 2 to 5 years after Y90 will develop late liver failure, not from their cancer, but from the radiation.